for like a year.
Well, good morning and good afternoon to everyone. Welcome and thank you for participating in this ISMP webinar titled Opioids in the Acute Care Setting, Safety is Within Our Reach. And we'd really like to thank and we greatly appreciate the support of Fresenius Kabi. It's allowing us to get a large number of people on this call today and helping us to spread the safety message when handling opioids. My name is Mike Cohen. I'm a pharmacist and I'm president here at ISMP, and I'm going to be serving as the moderator for today's program. And this is a topic I think that's engendered great interest as people look for ways to avoid many of the problems that we've seen in hospitals and in ambulatory care in the past. I do think we're making progress, although we certainly have a long way to go, and we'll hear about that today. Some of the safety issues that were common in the past, though, have been on the wane. They've been decreasing based on data we've collected here in Pennsylvania and with our hospital reporting program, and we'll talk about that in a little bit. For example, just one example that we see little of anymore with hydromorphone injection. It was very common to see much higher starting doses just a few years ago, often in non-opioid tolerant patients. We'd see sometimes as high as 2 to 4 milligrams given and as a starting dose. And it was not uncommon to see pre-filled syringes of 4 milligram on nursing units, where it was sometimes confused with morphine 4 milligram pre-filled syringes. So not only did we have a very high starting dose for patients, the equivalent of over 20 milligrams of morphine, but we also had these mix-ups occasionally reported, and we really don't see that anymore. I think people have been educated, about this problem, and the starting doses we now see are much lower, typically from 0.2 milligram to 0.5 milligram. So this is all good news, and patients are adequately treated for their pain most often with those doses, the lower doses, and we don't see the same risk that we did in the past. And that's just one example, and I'm sure our speakers will be discussing other ones a little bit later. Manufacturers are making these lower doses available in pre-filled syringes, including our sponsor, Fresenius Kabi. And there's much more, obviously, that's needed to improve safety, and that's why we have our experts with us. So let me introduce them, and we can get started with the program. So our first presenter today, and I'm going to introduce both of them now, and they'll go from one to the other. Our first presenter is going to be Matt Grissinger, and he is a pharmacist who works here at ISMP. He's one of my colleagues, and he is the person that directs our reporting programs at ISMP. And he also he has kind of a dual job because he also serves as the manager of medication safety analysis for the Pennsylvania Patient Safety Authority. And I don't know if you're familiar with that program or not, but you should look it up on the internet. They publish an advisory quarterly that is absolutely excellent, and it doesn't just cover medication errors, but all types of medical errors. It really helps you to develop a frame of reference for many of the problems that you'll run into in practice. So please do look that up. They published a patient safety advisory. Matt is a frequent speaker on pharmacy topics and current issues in medication safety. He's got regular columns on medication safety in the journal P&T, and also the Pennsylvania Patient Safety Authority's Patient Safety Advisory that I just mentioned. Among other appointments, Matt also serves on the National Coordinating Council for Medication Error Reporting and Prevention, better known to people in patient safety as NCMERP. And he also serves on the National Quality Forum's Common Formats Expert Panel, and he's actually got a history of being one of our fellows. He was one of our first fellows here at ISMP, and then we were fortunate to have him stay on with us. So that's Matt, and he'll start out. And then another colleague of ours is also going to be presenting, and that's Maria Foy. And Dr. Foy is a clinical pharmacy specialist in palliative care at Abington Hospital Jefferson Health, which is a 660-bed community teaching hospital 15 miles outside of Philadelphia, so not far from our offices in Horsham, Pennsylvania. And Maria graduated from Temple University School of Pharmacy and later got her Doctor of Pharmacy degree from the University of the Sciences in Philadelphia. She was involved with the ASHP Foundation Pain Management Traineeship and is certified in pain management and education through the American Society of Pain Educators. Maria also has earned her board certification in pharmacotherapy, this BCPS designation, and recently she received a safety award at her institution for her work in developing safe opioid prescribing practices. And I've heard Maria speak many times, and she's excellent. And I guess perhaps endorsement could be said, and the fact that Maria has cared for folks in my own family, and she's always done a terrific job with that. So we'll start out with Matt, and each speaker is going to present about 30 minutes or so, and then after the last speaker, we'll have 30 minutes for questions from the audience. If you do have a question for a specific speaker, that'd be great if you could jot down the name of the speaker with your questions so that I can direct it to that individual. If you are logged in on your computer, please submit your questions on the portal you can see to the right of your screen under the questions pod. If you are logged in using the mobile app, you can ask a question by clicking the question mark located at the top of your screen. Do feel free to submit questions throughout the presentation. In fact, we'd appreciate that. And the fact is we won't be taking any by phone because we have so many folks on the call today. We want to get right to the questions, and it's best to have them in writing. And by the way, if you'd like a copy of the speaker presentation, you can access it under the Handout tab on the GoToWebinar portal. So with that, let's begin. And let's start out with Matt. Matt Grissinger. Go ahead, Matt.
Thanks, Mike, for the nice introduction, and welcome everyone to today's webinar that Mike already described. So what we're going to do is I'm going to talk probably about half an hour in regards to some of the medication safety, medication error aspects of opioids that we have seen at ISMP, and have Maria follow up afterwards to go over some more of the clinical aspects of pain management and opioid use. So throughout today's webinar, we're going to talk about some of the causes of med errors associated with opioids and hydromorphine as examples. We'll throw in some aspects about describing methods to identify risk. So how do you know whether your organization has problems with the use of opioids? We'll go over some strategies and actions to prevent harm with use of opioid therapy, but also at the end talk about how to select appropriate therapy, not just opioids, but even non-opioid therapy for pain management. So first, let's go over some things that we've seen at ISMP and the Patient Safety Authority in regards to issues with use of opioids. And I think one thing I want to make comment here, you notice that the slide says contributing factors not identified through voluntary reporting. Now, if everyone on the phone thinks about the type of reports you may have seen involving opioids in your organization, often it revolves around wrong drug errors and maybe wrong dose errors, and often focuses on frontline staff members and why these issues are happening. There's a lot of things that contribute to an error that I rarely see mentioned in error reports, and that's why I think part of this we're going to talk about those things that we've identified at ISMP. So, for example, let's start off with the prescribing aspect of using opioids. And there's a lot of things that we've seen, and I have some evidence coming up for some of these things, but just the issue of knowing what an equity analgesic dose means and how do you convert from one to another. Maybe it's from a morphine to a hydromorphone or to a fentanyl patch, but also an IV to PO change as well. So what does that look like from the prescribing end, but also organizationally, what do you have set up? And we'll go over some of that later. Secondly, just improper prescribing. And this sometimes ties into that third bullet with your order set. So we'll go into facilities and think about all the order sets in your organization that include opioids. So it's not just for pain management per se, but it's for anything. Post-surgery is one example, OBGYN, any pain medications for that level of care. And these order sets will include many opioids. So it's literally giving the physician the choice of many different type of opioids to use with probably very little guidance. And what we've seen over the years is the prescribers will just order everything and now put the thought process of who should get what when down to the nurse, which is may not be that big a deal, but when you have many, many different nurses interpreting subjectively what to give when and how much and how often, you start running into problems. So the mere fact that we're even allowing that choice of all the opioids on the order set probably sets you up to fail to begin with. And lastly, on the bottom part of the slide is failure to consider patient information. So what type of things about a patient would potentially warrant the lowering of a dose or maybe even a change of an opioid from one to another? There's many clinical conditions or issues of patients that would impact that dose. Age is one example. Now I can't say everyone who's 80 you should lower the dose, but people who are 80 can be slow metabolizers, often probably not going to be obese, smaller people who will have probably more profound effect on any sedative drug, including opioids. Other comorbidities, renal status. Is anyone consider looking at renal status with the opioid that you're prescribing? Will that have an impact on how long it stays in the system? Opioid status. Is the patient opioid naive or opioid tolerant? And I'll discuss that in my next slide. And also the incomplete reconciliation process, which ties into opioid status. So it's above and beyond just asking a patient what medications are you on, but also asking them if they are on an opioid, okay, so how much opioid do you take in a day? How long is it, 24 hours a day? How many days in a row have you taken it? Because that's vitally important to determine opioid status is not so much what they're on, but just as much how much they're getting and for how long they've been getting it. And that ties into this slide. And there's also one aspect of identifying risk in your organization. So as a background, this is a graphic of a knowledge assessment test that we did with the Hospital and Health System Association of Pennsylvania and the Hospital Engagement Network projects that are run by CMS. Currently, they're HEN projects, and I know we have people on the phone involved in the HEN projects now. So as a part of that project, we had organizations sign up to be a part of the AD project, and we had established an 11-question opioid knowledge assessment test to get an idea of the level of knowledge about opioids by practitioners. And what's important to know, we had over 1,750 complete the test, and 30% of the people completing the test were prescribers. Half were nurses, 18% were pharmacists, et cetera. And so what you see on the slide is the answers to the first question. The first question was a question that stated, which of the following orders would make a patient opioid tolerant? We listed 4 orders, and the 5th answer being all the above. The correct answer was someone getting Percocet at least 4 or 5 times a day for 7 days or 10 days in a row, something that made someone opioid tolerant. Unfortunately, half the people who took that test, half of them chose all the above. So think about what the implications that means. So people are out there thinking, well, if someone got 2 or 3 doses of a Percocet or morphine, they're tolerant now, which is totally not true. So this, on this slide here, are the percent of people who actually got that first question right at all. So you see in the left-hand part in the blue here is the overall response. Only 20% of the people got that correct. 34% of doctors got that correct. And of all the practitioners who did the best were pharmacists, and we still did not even get 40% correct on that test. And so the big question for you is, in your organization, how do you know about the level of knowledge about opioids? By doctors, by nurses, and by pharmacists, or anyone who has to touch a patient on pain therapy and opioid management. Because this also kind of shows you why it's important to have organizational strategies in place to kind of take this into account. So there are things you can build in place to kind of make up for this in some ways. So let's give an example here. Another form of identifying risk that we had done in the project was we had put together an opioid organization assessment. So this was an opioid-specific 45-item assessment that we did for the project. And we're also coming out at ISMP with a high alert assessment later this summer, which will also include an opioid section. So people are listening in should just be on the lookout for that assessment later this summer. Now, in that organization assessment, we asked the question. You see numbers 7 and 36 here. They're both asking the same question. The 7 is just for general opioid use, and 36 is specifically for PCA use. And we asked organizations what items or elements are patients screened for in regards to issues that may affect the dose, monitoring parameters, or appropriateness of opioid use. So you see in the top right here, it says asthma, COPD, sleep apnea, opioid status. These results are telling you that only 35% of the organizations admitted that doctors assess for asthma or COPD prior to prescribing an opioid. Next column is saying only 29% said that doctors consider sleep apnea when prescribing opioids. And what's scary, of all these results, the scarier is the PCA line, where 25% said that they assess for sleep apnea. And I personally thought that knowing about sleep apnea and PCA therapy was older than the hills, at least 10, 15 years old. But yet, organizations were admitting that prescribers are not assessing patients for some key patient information issues like you see on this slide. So let's move on to dispensing issues. And some of these aren't really surprising to anyone. You know, Mike alluded to some look-alike drug packaging and labeling, but that also includes storage too, and we'll come up on that in 2 slides. Your distribution of unfamiliar products and concentrations, and part of that is really the drug shortages nowadays. It's tough to even find opioids, right? And then when there's a change in concentration, so what does that look like? How do people know that your morphine that was 1 milligram per ml or hydromorphine that was 1 milligram per ml, now you can only get 2 milligram per ml? How do people know that? And I know people throw stickers and warning labels and stuff that often get missed. Third item, how about when pharmacists do order entry? Does anyone have a pharmacy order entry system that screens for doses? So does your system know if a patient's opioid naive or opioid tolerant? If I accidentally put in a dilaudid 2 milligram order for an 80-year-old, what does your system do? More than likely nothing. So just keep that in mind with CPOE and pharmacy order entry systems, that unless something is built in, it's probably not even screening for high doses. And then also we have access to opioid status, or do pharmacists even know what opioid status means? Are they, when a pharmacist reviews an order, are they thinking about those items we talked about in prescribing? Because it applies to pharmacists too. Do they know about how much opioids they've been on, how long have they been on it, etc.? So on this slide, going to the issues of lookalike names of packaging that Mike alluded to earlier, this whole our recognition quantitatively came out with an advisory we wrote many years ago that was, you'll see, published in 2007. When we looked at the most common pairs of drugs involved in wrong drug errors, and see if my animation is going to work here or not. We're going to zoom in here, and you'll see in this list, these are the top drugs in no particular, I should say, not in any particular order, but it's kind of odd when you look at the top 10 list when it includes morphine and hydromorphone, generic Vicodin, generic Percocet, short-acting, long-acting oxycodones. You'll see alprazolam, lorazepam, Tylenol 3s, Percocets, plain oxycodone, Percocets. But you notice a theme here, everyone? This wasn't the top opioid list. This is the most common of all drugs, and opioids came out to the top. So why is it that these are often involved in wrong drug errors, or at least the most common types of pairs? You know, think about look-alike names, morphine, hydromorphone, and the hydrocodone, oxycodone is a killer. There's one example. Part of it is storage. How do you have it stored? Are they sitting next to each other where it's easy to pull one instead of another? Also, pure availability. When you look at all the opioids on this list, does your organization really need all these opioids? Every one of them? So it's the whole issue of the kid in the candy store routine, and when you have this choice of opioids, and also when you think that someone has pain, you give opioids only, kind of sets you up to some of this failure as well. Mike did a talk earlier that we did relook at at least the morphine hydromorphone mix-ups in Pennsylvania, and there has been a pretty dramatic decline in at least events being reported that involve mix-ups between morphine and hydromorphone, to the point where I think, if I'm correct, this is cut down in half since that time period. So clearly, I'm hoping we're seeing a difference, and hopefully the reporting is showing that. Yeah, but again, think about it's not just the look-alike names, look-alike packaging. It's also what do you have stored? Where is it stored at? For the pharmacist on the phone, Do you evaluate storage areas by observations to see how things are stored? So look at this picture here, and I've run into similar situations as well out with ISMP on consoles, where I was in one procedural area one time and went to a locked box on the wall, and that's where they had narcotics. And they only had 2 narcotics in the locked box, and you know something? It looked just like this picture on the screen here. See the 2 open boxes here? They were stored exactly like this. Any problem with this here? No labeling, tops are pulled off, unlike this one here. The only issue is this one box is morphine, the other box is hydromorphone. And what happens if they even had similar concentrations of 1-to-1 or whatever it may be, right? And you pulled hydromorphone in air of morphine. So we're talking a 5- to 7-fold overdose that really originates how it's stored and what it looks like here in this picture. Let's go to administration stuff, administration issues. So, a couple things. What do your policies and guidelines look like? Not just for nursing, but everyone. When we did that organization assessment for opioids the first time around, at that time, about a third of my hospitals admitted they had no pain management protocols. Nothing. So how are nurses supposed to monitor patients? And we're going to come over monitoring in the next slide. Number 2, concentrated oral solutions. I'm thinking of the morphine 20 milligrams per ml. That's only indicated for opioid-tolerant patients, hospice patients, palliative care patients, etc. Yet we'll see hospitals dispense 30 ml bottles of 20 milligram per ml morphine on regular med-surg floors. And think about what could go wrong. It's 20 milligram per ml, and say a patient has an order for 5 milligrams, and say accidentally a nurse gave 5 mLs. That'd be 100 milligram error, 100 milligram as an overdose. So just having that around on floors inappropriately is setting you up for failure. Next bullet, knowledge of equity analgesic dosing, again, applies to everybody. Dosing confusion we touched on. Our organizations using smart pumps and have libraries built for both regular infusions of morphine and or PCAs, and what does that look like as well? Here's one aspect that really concerns me, really at the end of the day, is monitoring. How are nurses supposed to monitor patients for opioids? So they're on opioids and other sedative drugs. How often does that assessment look like? When do they go into the room? When do they go back into the room? Do they assess before and after giving an opioid? Keep in mind, in many units, that's still a manual process. I'm talking ICUs here. I'm talking med-surg floors and other areas where they may not have technology to help monitor for the effects of an overdose of an opioid. So there's a variability when assessments are supposed to be done, and Marie may touch on this, but think about some drugs have a longer half-life than others. Some work rapidly. Some don't have an onset for an hour. So when do they go in based on the opioid? Do staff know what to assess for? But more importantly, in addition to staff competency piece of it, what's your organization's policy and practices around what you expect nurses to document and assess for, and what does that documentation look like? What type of equipment is available? And so again, we'll go to the med-surg floor. They may have pulse ox on, depending on the type of patient. They may not have capnography at all. So what has been your organization's approach to using end-tidal CO2 monitoring to monitor how much CO2 is being pushed off compared to pulse ox? When the pulse ox is okay, the problem is usually by the time that thing starts to alarm, that patient's already been going downhill, down the roller coaster ride, and it's a matter of when you caught them when they've gone downhill. So it's not a good early indicator, but it's kind of almost like a last end catch in a way. Location of patients. Which patient do you think will be assessed quickest? The one nearest the nursing station or the one at the end of the hall? When there's, again, no alarms for this, no technology to help you alert there's a problem, we're relying on people walking into rooms to figure this out. Structured handoffs between departments. Someone gets opioid in the emergency department, how does the floor know that? I know everyone on the phone battles with that, right? The whole communication of what's in the ED, you get to the floor with an anticoagulant opioid, what's that process look like? I've been in hospitals due to the variation or variability of electronic health records where the hospital have system 1 and then PACU had a totally different system that didn't communicate with system 1. And so nurses and pharmacists would have no idea what opioids patients got in the PACU, because they didn't have access to the PACU system. So unless you called every time to know what they got, you had no idea what was going on. And lastly, how about monitoring an ED? So if someone gets an opioid like hydromorphone in the emergency department, what is the protocol or policy around how long does the patient stay in the ED before you let them go? We have been involved at ISMP a couple RCAs where patients have accidentally got overdoses in the ED, but due to patients wanting to leave right away and other issues, they left and ended up dying at home. And it originated on the prescribing and administration in the ED and lack of criteria of when you keep people in the ED to monitor them before they go home. Back to that organization assessment again, one of the issues we also had, one of the questions we had is we asked organizations how they assess patients for opioids. So this is a 4-part question. This is 2 of the parts where we talk about specifically parenteral opioids on the top here. The blue is what do hospitals assess for prior to administration, and the red is what do they assess for after administration of the opioid. So on the bar graph, you'll see the groups of respiratory rate, quality respirations. You see what people admit they were assessing for. Pain level clearly was high on the list. Look at some other things that weren't so high. Quality respirations, 70% did quality respirations. Respiratory rate, heart rates were lower. Well, what's really, to me, scarier is why is the red line lower than the blue line in all of these? This is implying that hospitals admit that they're assessing patients less after giving the drug than before giving it. So what does your organization look like in regards to assessing a patient? What are they assessing for? Often people just go by respiratory rate, which is not a good measure. They may have pulse ox, which is not the best measure. And, of course, they'll do pain level. Well, how do you assess for sedation? Even things like blood pressure, believe it or not, can actually have a little bit of an indicator that something may be going wrong. So it may not be as great as level of sedation, but these other things, quality respirations. How do nurses assess for quality respirations? How is that documented? So a lot of issues here with monitoring as well. What I'll branch into here is we also did another advisory appeared in 2010 for the Pennsylvania Patient Safety Authority where we specifically look at issues associated with hydromorphone. So we're looking at, in a statewide mandatory medical error reporting program, medication errors associated with hydromorphone. And so we actually do an analysis by reading all the event descriptions to tell you what people are telling us in the event descriptions. So, for example, when you just look at the medication error piece, these are just the most common event types that were reported. And overwhelmingly, but clearly overdoses were number 1. And these, by the way, think about this, these are, based on my experience reading these reports, these were not prescribing issues. And I actually was a little disappointed because many of the reports, if not most, involved nursing issues. And very, very little prescribing issues or pharmacy issues. So this is a little skewed. It's predominantly what's coming from nursing. So these are going to probably be the misselection errors as compared to misprescribing the wrong dose, as an example. Wrong drugs are second on the list. And notice, by the way, number 3 were issues with documented allergies as well. So not looking at the allergy information and taking that into account when ordering medications. At that time, looking at wrong drug errors, what's fascinating here, so these are all the wrong drug reports that mention hydromorphone. And look at the top 2 pairs. So the first line is saying that hydromorphone was prescribed, but morphine was given, and that happened 35% of all the wrong drug reports. That's over 35% of the time. Second on the list, morphine's prescribed, hydromorphone accidentally given, and that is 34% of the time. So you add those 2 together, right? That's going to be, quick math here, almost 70% of the reports involve morphine hydromorphone mix-ups. Look what's next. Lorazepam, 3%. Meperidine, 3%. So look at that huge jump between that. So if you're worried about any wrong drug errors with hydromorphone, clearly it's morphine over anything else. But, as I said earlier, the reason we went into doing this advisory in the first place was stuff that ISMP had saw out in the field in regards to the lack of knowledge of opioids, of hydromorphone dosing especially. So that's why we did this analysis. And honestly, the medication errors, again, were predominantly nursing, very little prescribing stuff, not enough to like knock me off my socks and think, oh my God, this proves we have a problem. So what we did, we also looked at reports that were submitted as unpreventable adverse drug reactions, which can also be submitted in Pennsylvania. So we took a look at, you see in the slide, 937 adverse drug reaction reports submitted in that time period. So I had a fellow, Hind, who's with us, and I had her go through all the event descriptions. And in one column, just write down what was the reaction that the patient experienced. So this is an ADR. What was the reaction, right? So what do you think the most common reaction that was reported involving hydromorphone? Many people will think highs, allergies, itchiness, etc. Overwhelmingly, well, I should say overwhelmingly, almost half the reports were CNS respiratory depression. So think about this. So almost half the reports involve CNS respiratory depression. Now, when I first saw that back then, I fell off my chair. Then I talked to some people to make sure I wasn't nuts. Like, listen, this is a dose-dependent issue, right? I'm not missing something here. Or a patient information issue as well. And so confirm that. So then we took this 441 reports here, and then we went through and set up some criteria. So the criteria you'll see on the top of the slide. We looked at those reports, and we evaluated that report to see if we deemed that event could have been preventable. So the criteria we set up were if it was an adult patient and received more than 1 milligram of hydromorphone, which is already way too high, elderly patient received 1 milligram or more, the patient received multiple medications that cause sedation, or, and yes, believe it or not, in an unpreventable event, they would mention patients would have sleep apnea or other complications. So if any of these were met, we deemed it preventable. And keep in mind, this hydromorphone is being very lenient in regard to dose. Well, when looking at the CNS respiratory depression reports, 65% of those reports were preventable. And it was scary to me, or reports like this example was published in the advisory. This is actually a real event description. An adult patient was admitted with abdominal pain, received meperidine 25 milligrams IV push at noon and 1 p.m., followed by dilaudid 2 milligrams IV push at 2, at 3, at 4, and at 6 p.m. What do you know, at 7 p.m., they were difficult to arouse and got Narcan. But what does this tell you about the perception of this organization? I mean, they submitted this as an unpreventable ADR. So people are out there thinking, oh, well, you know, we overdosed them with an opioid, we'll just give Narcan, they're fine, if they were caught. How egregious is this order, everyone? All right, so think about that. And again, how do you know your practitioner's level of knowledge with drugs like hydromorphone? Okay, so recommendations, and I'll pass it over to Maria. Some strategies. Number one, patient assessment. What does that look like? So who is assessing the patient when they come? Well, assessment as in nursing assessment, but also reconciliation. Who's assessing the med profile? How much opioid they've been on? What are your resources or guidelines do you have for the safe use of opioids, like hydromorphone as an example? Unfortunately, hydromorphone has tended to get a bad rap, and I know Maria will be talking about that. You know, hydromorphone is a great pain drug for pain. It's just that we're not using it right. And unfortunately, the drug is getting blamed for our misuse. Also, you know, support safe communication drug information about how we communicate orders, what barriers, or place barriers around distribution and drug selection. You know, where do you have drugs like hydromorphone stored now? At what concentrations? Do you have a 4 milligram per ml hydromorphone laying around somewhere, an OBGYN unit? Pharmacists on the phone, have you gone out and looked at that storage of what is actually out there? You know, consider ways to differentiate them. You'll see a good example here of the new dilaudid, which is coming back out in the market on the bottom left here. Obviously, is clearly more differentiated than the morphine compared to just hydromorphone here in the label. So I think this will help at least with selection errors by just seeing how different those two products by color and by drug name are. You know, can you employ technology in regards to at least monitoring the drug? How about doses when you do an order entry systems as well? Have you considered capnography? And you know, I've seen both ways. People love using it. I know small hospitals have bought it for everybody, and some people who are afraid to go down that path. So that's still a work in progress with use of capnography. But also think about how you're monitoring patients. I would really do a thorough mode effects analysis on opioid monitoring. If you can do any FMA and opioids, how are patients being monitored, how often, what are they being monitored on, and what are they being assessed for. Think about any policies or any work around equity analgesic dosing as well. It's just also already part of the EHR system. They can convert it over for you. But you also need to identify risk in your organization as well. And I have one more slide here before I pass to Marie. Currently, Maria. So, for example, how do you know right now if your organizations have issues with opioids like morphine or hydromorphone or fentanyl? So, we obviously rely probably a little too much on AIR reports. And when I say a little too much, meaning it ends up being looked at from a quantitative perspective, but not a qualitative, what really went wrong in this event, what are multiple things that went wrong. So it's not just reports, but also maybe RCAs and FMEAs. How about looking at ADR reports? After what I just showed you, I would really recommend taking a look at those reports submitted as unpreventable ADR reports of opioids and just question them. Just look at the dose and look at the age of the patient and see what they got, how often, to see if it was really unpreventable or not. Any pharmacy phone calls in regards to correcting orders for pain management as well? Can you track and trend the number of calls you had associated with opioids? Can you measure the use of naloxone, the use of triggers, just to get an idea of the level of harm to patients? So if someone gets naloxone, predominantly it'll be because of oversedation, CNS depression type of thing with opioid. Yes, it definitely have given naloxone for stuff like itchiness, etc., but it's still some way to give you a more accurate measure quantitatively than an AIR report ever will. One thing we do in our project, we also measure rapid response team calls. We've learned at ISMP that everyone has some sort of rapid response team or something to that effect, but we've also figured out that these teams rarely investigate why they were called. They go rescue patients, but no one actually follows up to say, well, was this preventable or not? Was this opioid related, and was it preventable or not? Any data from technology, from using barcode reports to smart pumps as an example, to see any trends in regards to misuse of technology with opioids. How about falls? We have people in the HEN groups monitoring falls. How many falls are associated with opioids? Do people call it that number at all? I don't know if I've ever seen that number out there that kind of associates or gives me a percent of how many falls are related to medications. Now, the ones related to medications, how many times were opioids implicated in that? And also external sources of information. So Mike talked earlier, the ISMP newsletters, our high alert assessment coming out in, later this summer, Pennsylvania Patient Safety Authority advisories. We have a whole section on opioids in that website as well. So there's a lot of ways to identify a risk. Make sure you try to employ as much as you can on this. So on that note, I'm going to pass this off to Maria. Maria, it's all yours.
Thanks, Matt. So today I'm going to talk a little bit about the safe prescribing of opioids. What is the proper patient that would be a patient that should get an opioid? What kind of comorbidities do they have that we may need to worry about? Oops. Sorry. So we really have an issue in this country. Unless you've been off the grid, you may have not heard about the opioid era, but just about everywhere we turn, we're hearing about opioid errors, opioid crisis, people that are dying now from opioid deaths. So we see an increase in prescribing as being part of that issue, where opioid prescribing has increased fourfold since the 90s, and opioid deaths have followed. So we're seeing just about as many opioid deaths going up as we see the increased prescribing. But on the other hand, we have 116 million people affected by pain each year. So it's really a dichotomy here. What's going on? Why do we prescribe the most opioids? Why are the most people dying, but we still have pain issues? One of the questions that we need to ask. Other things, diversion and proper use contributing to the crisis. Who's really dying of opioid deaths? Is it the people being prescribed the medications, or is it the people that maybe are just abusing them and stealing from the people that maybe prescribe the medications? And we're seeing a lot of opiophobia. It's becoming more and more common. I hear from so many of my patients that now they go to the drugstore and they get treated like they're an addict, and they've been on these opioids for 10 years. They function. They do really well. and now they're being treated differently because of the crisis, where we feel that maybe nobody should get an opioid, and that's wrong in our thinking. So the pendulum is really swinging. We have pain, high amount of pain patients, despite using the most opioids in the entire world. As these opioids increased, so did the inappropriate use. So in 2013, they saw about 34,000 opioid deaths, and 37% of them were for prescription medications. And about 19% of deaths were due to heroin. So you really see a big heroin use going up here in 2013, and that's something we really have to worry about. So our opioid deaths have quadrupled in the last 15 years. These are some slides from the National Institute of Health, just highlighting some of those increasing in prescribing. The first, on the upper left-hand corner, you see that the number of deaths from all drugs is 60,000. From opioid drugs is about 35,000. From prescription drugs was about 18,000. And we just heard recently that the opioid prescribing practices have stabilized. They're not really going up as much, but there's still many opioids being overprescribed. But what I really worry about is we're taking the supply away from some of the people that are abusing the opioids. And if you look, from 2002, there was 2,000 heroin deaths, and in 2015, we're seeing close to 14,000 heroin deaths, and I worry with just taking care of prescription opioids if this opioids crisis is really going to end. So for hospitals, the Joint Commission just came out with new standards that will be in place from January of 2018. And these standards involved making sure that practitioners are involved in assessment management, in the safety of opioids, how do we screen patients, how do we assess, and as you know, Matt was saying, how do we reassess this pain, and what are we looking for on reassessment? What are we doing in the ER during the visit and at admission? That's also a problem that Matt had talked about with discharging people on opioids and maybe not using the right doses. How do we communicate to our patients? This, I think, has been a big issue over the last 15 years, where we've been prescribing opioids for non-cancer pain. And now these people are on high doses, and they really are having a hard time going down on their medications. But once you try to talk to people and talk to them about their pain, maybe you can't find anything wrong with them, but they're still in severe pain, we have to kind of convince our patients that the pain system's broken. We need to give them their objectives of treatment. We need to put things to patients as if it's a trial for opioids, not that you're going to be on this forever and we're going to go higher and higher on these medications as we had done in the past. We need to monitor for risk of adverse reactions. And like I said, education is important for the patient, especially in the hospital. The Joint Commission is saying now at discharge, we have to educate our patients on side effect management, on the patient's plan, on the adverse effects and activities of daily living. What we're looking for is increase in function, and how do we store these meds safely? The leadership changes, the standards are going to be, like I said, in effect in January 2018, and we are now looking at pain management to be recommended as an institutional priority. In the past, especially where I feel that opioids in the institution were kind of not really looked at. Now with this crisis out there and these increases in deaths and seeing all these patients coming in, I think it's becoming more forefront in the C-suite. So there's going to have to be some type of pain management program and institutional priority where you're going to look at performance improvement activities, provide education to the patients, resources. Using PDMP, we're finally in Pennsylvania able to use PDMP, which has been a really big help to find out not only what patients may be abusing opioids, but what patients are on when they come into the hospital. And we need to identify treatments for needed referrals, especially for when we use opioids and abuse them. So I'd like to go with a polling question. I'll give you something like 15 seconds, 30 seconds to answer. And we'll supply the results. So the question is, the majority of opioid deaths are in patients prescribed opioids. Is that true or false? Okay, 2 more seconds. So the results, hopefully we'll have them.
So it looks like about 61% chose false.
So false is the correct answer. We have, with the opioid deaths, it's actually 70% of the opioid deaths. The people have gotten the opioids from a friend or a relative. They've actually taken it from them, went into the medicine cabinet, and got it from someone else. So the people that are actually prescribed the medications aren't the people that often are the people that are dying from these medications. Okay. Oops. So we need to create a safe pain management strategy in our institutions. And this is my big deal, that patients in pain deserve treatment, even those with a current history of substance use disorder. We have a large population of sickle cell patients here, and there are some that do have some issues with substance use disorder. However, when they're in crisis, and I know they're in crisis, I can tell they're in pain, and these people deserve to have their pain treated. Once they become out of crisis and you change them over to PO and they still want their IV, oftentimes they'll leave AMA or do whatever they need to do. But they do deserve to have their pain treated. We need to do a risk assessment for substance use disorder. I think we were putting opioids on patients, had no idea who would be at risk. So that assessment's really needed, and we have some tools that we can use for that. We need to develop a treatment program based on the risk of the patient. Is there a low risk? Is there a medium risk? Is there a high risk? And the high-risk patients, would you even think about using opioids? Maybe you would try to do many other multimodal therapies, maybe some interventional therapies. But if someone is substance abuse disorder and they have metastatic cancer, opioids may be your only choice. So we really do need multimodal treatment. Multimodal treatment among your medications, meaning different classes of medications, using your NSAIDs, maybe acetaminophen, along with your opioids, along with some adjunctive agents. Maybe we need some use of complementary therapies. We're seeing a lot with massage and meditation out there being used for chronic pain. And we want to increase monitor of opioids. We really need to monitor our patients more often, especially if they're at that more of a moderate to high risk. Our next polling question, what is the first step in assessing pain? Number 1, perform a urinary toxicology screen. Number 2, complete a pain assessment. Number 3, obtain your CAT scan imaging. Or number 4, order blood work to rule out infection. So what do you guys think? Two more seconds. Oh, now we have the answers on the screen. 99% of you are correct. Completing a pain assessment, finding out what's going on with the patient before you do anything else. If we were to perform a urinary drug screen on every patient, I think that we'd probably go broke. CAT scan imaging is often not helpful depending on what you're treating, and blood work to rule out infection kind of doesn't really often go along with the pain picture. So what can we do to try to find out who would be an appropriate patient to be on opioids? There are different screening tools available. The opioid risk tool is nice and short. It's not very long, and it will give you an idea of low, medium, or high based on the person's answers. We also have the screening and opioid assessment for patients with pain, the SOAP or the SOAP revision. That's a bit of a longer tool to use, but it will give you more sensitivity into knowing if that patient may have an issue. We now have the prescription drug monitoring program in Pennsylvania, and I believe it's available in at least 49 out of 50 states. We were the 49th. I believe Missouri might be left if they haven't had one in place yet. So using the prescription drug monitoring system is not perfect. They don't really tell you how the patients ordered the opioids. You may see multiple prescribers because patients were in the hospital and the hospital personnel were prescribing the opioids. So you really have to know what you're looking at. But this will give you an idea of exactly what the patient's taking. You can see if someone's using their PRNs, if they look to be using them every month based on their refill patterns. So you know, kind of get an idea what your patient's using. Random urine drug screens can be very helpful. Another thing with these is know how to read them. Know if it's an assay versus a confirmative test. In our institution, we used to confirm all our urine drug screens, but then went into a different lab that only does the immunoassays. So it's very important that our practitioners know that if something comes out positive, it could possibly be a false positive, and to get that confirmed. And treatment agreements, you give the patient an agreement. It's not a true contract that you can take someone into court with it, but this at least gives the patient the expectations that we're going to be monitoring them for any type of substance use disorder. So what are our risk factors that we have to worry about? One of the big ones is a family history of inappropriate substance use. So that's a big risk factor, a personal history of addiction or chemical coping behaviors. So I heard this at a conference, and I think this is really true because it isn't just addiction and pain control that we're dealing with. There's so many people that may have anxiety and depression and are using the opioids to treat these conditions, and I call them chemical copers. In all patients with substance use disorder or addiction are chemical copers, but not necessarily all chemical copers suffer from substance use disorder. In some patients, when the anxiety and depression become very severe, their pain system actually becomes sensitized and they're having more pain, and the opioids are not the proper choice for that type of pain. But in a lot of patients, we've already got them on high dose of opioids, so how do you convince them that they need to be on something else? So we can also look that current inappropriate substance use can increase future risks. Alcohol and cigarette smoking are legal, but if you have someone that has excessive alcohol use or someone wakes up and has a cigarette within the first 5 minutes after they wake up, that may be a risk factor for abusing opioids. So we need multimodal therapy for these patients. Utilization of more than one treatment approach and utilization of more than one medication type. For the treatment approaches, we have our pharmacologic treatment, but we also need to know our non-pharmacologic, interventional. Can anything from acute pain management service, any type of intervention be done, any type of injection, block, things like that? What are some complementary medicines that may be able to be used? Can we use meditation? Can we use massage? Can we use acupuncture? A lot of those things have been verified in certain pain conditions. And what are the psychological things that need to be treated? I think this is the most important piece because patients with anxiety and depression often sensitize their pain system or may eventually become so dependent on their opioids that addiction may be in the next step. And what do we do now? We're taking patients' meds down, we're taking their doses away, and we're not being able to treat what they have as far as their pain driver or what their substance abuse or mental status issues are. So we're taking away supply. We really need to do something with the demand. Otherwise, those heroin deaths are going to continue to rise. So we need that multimodal medication treatment. So use of adjuncts, use of NSAIDs. And you can use these things together. Oftentimes I have someone in severe pain and I recommend Tylenol around the clock. And I get, well, Tylenol's not going to do anything. Acetaminophen's not really going to help around the clock, but it may help around the clock in addition to an opioid that you may be using. So this multimodal therapy, using different pain medications and pain therapies based on where they work in the pain pathway, is the way to go. These are just some treatments that we have and advantages and disadvantages. Our acetaminophen is for mild pain. The disadvantage of acetaminophen is overdosing on it and taking too much of it, which you have to worry about even in combination opioids, and using opioids acetaminophen from over the counter, getting too much in one day. NSAID use, it can work very well for inflammatory pain. Unfortunately for neuropathic pain, pain from either nerves that are damaged or from that sensitized pain, NSAIDs will not work. And then you're giving someone a risk for acute renal failure and gastrointestinal bleeding. So NSAIDs often can cause more severe adverse drug reactions than opioids in general, so we have to worry about that. Tramadol, I know everyone tries to use tramadol now because tramadol is felt to be non-addictive, but we are finding tramadol is now controlled and it is associated with addiction. I talked about using that we use about 95% of the opioids here in the U.S. They use tramadol over in Europe. And there's actually a tramadol crisis going on over there. With tramadol, it's because of the seizure potential and so many drug interactions that people will seize, and naloxone is not going to reverse that. So they may have you may die from seizures from tramadol. And I heard this statistic, and I haven't verified it, but I heard that more deaths occur in Ireland from tramadol than from heroin. So something to think about with tramadol use and all the drug interactions. And the thing with tramadol, it's also not very potent. We have our pure mu opioid agonists. Those are recommended for severe pain. And I did have something on here, no ceiling effect. We now know that that's not true. In our cancer pain patients, we really can go high up on the doses to control their pain and may need to go high on doses. But what we're hearing now for non-cancer pain, increasing those doses over about 100 to 200 milligrams of morphine equivalents a day is not going to offer much benefit to the patient and may only cause adverse reactions and sensitization of the pain system. A new drug that's a relatively new drug is tapentadol, and tapentadol is used for more mixed pain because it'll work on the norepi receptor, similar to duloxetine, one of our antidepressants, and that's recommended for severe pain and neuropathic pain. And what I understand is there's a lot less chance of abuse with tapentadol because it is a mixed opioid receptor agonist, and it doesn't have the affinity to the receptor, so therefore not as much of the euphoria. There is a ceiling dose with tapentadol, and it can be expensive, even though I hear more insurance companies are covering it. So for our last polling question, true or false? Every opioid will affect everyone the same way and will provide equivalent levels of pain control among different individuals. Is that true or is that false? Two seconds. That is correct. It is false. Everyone is individual, and pain management really needs to be individualized within our patients. We have different mu receptors. There's not only one, so everyone has different metabolism systems and different degree of enzymes that metabolize these drugs. So it may be that we need something other than someone else. So for acute pain, we want to, as Matt had said, to assess someone's opioid tolerance status. We want to understand those equivalents because if we have someone who's extremely tolerant, we need to use multimodal therapy for their pain management control because as we find now that opioid tolerance doesn't take away the risk for respiratory depression after surgery. We want to understand our equivalents to not underdose our patients too. We don't want to give them an opioid-naive dose if they are tolerant because that medication may not work for them. And interestingly enough, in our hospital, we are now a hydromorphone hospital, and I see more underdosing of pain medication than overdosing because we are so familiar with hydromorphone dosing now. I see patients ordered 0.5 of morphine, IV, 0.5 of morphine, oral. So we're looking at a dilated dose there, a hydromorphone dose, but we're giving it to someone morphine, and we're really probably ISMP doesn't hear so much about those errors as we do with the overdoses. So you have to know your equivalents. You have to be aware of options that should not be used for acute pain, such as a fentanyl patch or methadone, and your highest risk for overdoses during the first 24 hours after surgery. So looking at your patient, what comorbidities do they have for respiratory depression? And as Matt had said, assess for both pain and sedation. We had that in our recovery room policy, but found when we had some overdose errors that they were only assessing for the pain and not the sedation. So patients would say they were in 8 to 10 pain but falling asleep while they were saying that. Really, and that's an unsafe condition to give an opioid. But on the other end of it, the floor nurses didn't want the patients coming to the floor with a lot of pain. So they were really at an issue there as the patient was falling asleep to give more opioid medication. So understanding the risks and pain scores and what they mean is very important. We need individualization, as I said. It's not a one-size-fits-all. We want to pick our pain on the chronicity of the pain. Is it going to be acute? Is it going to be chronic? Where is the pain at? And what comorbidities does the patient have? As Matt has talked about, renal, liver issues, anxiety, depression, PTSD. I hear so many people that have issues with addiction have some sort of trauma from their childhood. And so the PTSD and things of childhood trauma are a big issue with opioid addiction. We want to know our patient's characteristics. We want to know a physical. We talked about age. check them for a risk of substance abuse, look at their comorbidities, and what have they used in the past that may have worked for them. Oftentimes, patients will come into the ER and they're telling the practitioners what worked for them, and immediately they're thought of as a seeker. But people know what worked for them, and it is not necessarily that they're seeking that medication, they're just seeking pain control. What kind of pain it is. If it's neuropathic pain, your opioids are not going to work very well for that type of pain. You need your antidepressants, certain antidepressants, anticonvulsants, some topical products can be used, but you have to give your patients realistic expectations. These medications aren't going to work immediately. They're going to take 4 to 6 weeks to control your pain. You may need to use something in between until they get to a good level. You may need to make sure you get to a therapeutic dose. Most people fail gabapentin therapy for pain because they don't get to a therapeutic dose. I talked about the chronicity, whether it's cancer pain, and in non-cancer pain, we're really being very cautious now about just using opioids for that pain, just giving a pill and expecting that to control their pain. What we're looking for now is improvement in function and looking for the risk of abuse. How do you choose? So you have somebody with severe kidney disease. Codeine and morphine should not be used. Now, in hospice situations, if someone's on morphine as needed, then they really don't have a lot of pain. Often they won't have any side effects, but you're going to accumulate metabolites, the M3G metabolite, that ends up causing something called opioid-induced hyperalgesia, which means that the medications are actually causing the pain, and opioid-induced neurotoxicity. You'll see patients start to have hallucinations, they'll start being more confused, sedated, and have, once you see myoclonus development, just that twitching of a limb, oftentimes that's associated with those metabolites. Fentanyl is our drug of choice for patients with severe renal or liver disease. Unfortunately, fentanyl is not really available orally. It is in the transmucosal formulations, but they're restricted to cancer patients, and you have to go through a REMS and be certified to use them. Most of our oncologists don't even know that they cannot prescribe fentanyl transmucosal without going through that REMS. And that's unfortunate because in true cancer breakthrough pain, the pain comes on fast, quick, it escalates, it's gone in 2 hours, and we're waiting an hour for our pain medication to work, where the fentanyl will work in about 5 to 15 minutes. Methadone is a good option in renal disease, but the dosing is complicated, so really you should have a specialist initiating and monitor methadone. Hydromorphone and oxycodone are relatively safe in renal disease. Where I see issues with hydromorphone, with that neurotoxicity and hyperalgesia, is someone that is going into acute renal failure. I've seen that happen where patients had gone down a few times from hydromorphone as they were going into acute renal failure. And we have to be careful with our long-acting medications and end-stage liver disease. If you don't, oftentimes they may be stacking up on your patient and may cause an overdose. So is morphine for everyone? We have some positives with morphine. It's the most studied. It's not expensive. There's tons of formulations of it. We even have studies on using MS-Contin rectally for chronic pain, that it gets absorbed and it gives you good blood levels. But what are some of the negatives? Where I talked about the renal failure. It does have the most histamine release. So in the ICUs, we don't generally use morphine. We use fentanyl because you're going to see hypotension. You're going to see different issues with the histamine release and their vital signs. They may have a higher incidence of GI adverse reactions, and there is some addiction potential, but we'll see more with other opioids. This one bothers me. A delayed plasma response is an issue with titration. So what that means is it takes 40 minutes to get into the plasma with morphine to cross the blood-brain barrier. And with hydromorphone, it's closer to 10 minutes. So if you're treating pain every 15 minutes and you're giving a dose every 15 minutes to treat that acute pain, like say in the PACU, that may stack up once that gets into the plasma in that delayed plasma response. Hydromorphone for anyone. You know, we've heard so much about the errors with hydromorphone, but we've gotten to the point where we're very familiar with its use, and it really does have a lot of positives. It's more potent. It has that quicker distribution. It's safer than morphine in dialysis. With morphine, the metabolites are not removed with dialysis. Hydromorphone metabolites are removed with dialysis. So that makes it a bit safer. For the negatives, we see higher dosing and end-stage disease. You might see some of those neurotoxicities and the potency mistakes with morphine. What about fentanyl? Is fentanyl safe? It's 100 times stronger than morphine. And it's drug of choice, though, in renal and liver failure. but many institutions do restrict their fentanyl use to people that are familiar with it. The microgram to the milligram amount may cause some errors, but it is an appropriate drug to use as an IV drug in many situations. And people are very afraid of that, but they're not as afraid of the patch. The patch is used extensively, and we're not really worried about it, but patches used in acute pain can cause a lot of issues. We have to remember that that onset is 12 to 16 hours. You need to tell that to your patients that it is a delayed onset and it could be problematic. So I'm going to leave you. I'm not going to read all of these, but these are some things that you can say for patients when you're communicating. You need to tell them that realistic expectations, that these pain medications are only going to take the edge off. May not be long-term. We may only be using this as a trial. We may decide on a future date that this trial isn't working out and you're not a good candidate for opioids. We have to give them those realistic expectations. We also have to know when to say no to people, when you're not comfortable prescribing opioids or when you're not comfortable continuing to prescribe opioids due to maybe some issues with inappropriate use, dirty urine drug screens, things like that. So, to finalize, patient and family education is key. We need to give our patients realistic expectations. We need to have them involved in their care. They need to be an active participant. They need to know that they can't just have a pill and expect that their pain is going away 100%. We need to look at increasing their function, not just decreasing their pain. We want to give patients their information on the risks and the benefits of opioids. We want to teach them how to properly store and dispose of opioids. We want to highlight the benefits of the non-pharmacologic therapies, PT, massage, acupuncture, different water therapies, mind-body techniques, and some psychological issues to develop better coping skills such as cognitive behavioral therapy or acceptance therapies. My references, and on that note, we'll take any questions that you have to offer.
Thank you, Maria and Matt. I really appreciate it. Very thorough. Great job. So we are going to take some questions now. Just a couple of very brief comments. Matt and Maria, both of you talking about potency difference between morphine and hydromorphone and the name mix-ups, which used to be a bigger problem in the past, but it is still a problem, especially around this time of the year, I think, when we have new people coming in. And we've had people think, for example, that hydromorphone is the generic name for morphine. They mix them up, and there is quite a potency difference, as we all know. I think it was good news to see that the word or the name Dilaudid was used on the hydromorphone syringe. That is something that we suggested long ago, actually, not only for it to be used, but we did attempt at one point to try to get that to be the generic name of the drug. So good to see it on a syringe, and actually that's from Fresenius, our sponsor for the program today. So I guess a little bit of an advertisement, but no, not really. That's a safety thing, I think, and important to know about. I would call it Dilaudid. I wouldn't call it hydromorphone. And then you used the abbreviation, Maria, PDMP, and there were some questions about that we got. And of course, you're talking about prescription drug monitoring programs, which are now ubiquitous throughout the country. We have I guess every state now requires that when a prescription is filled for a controlled drug, and all the opioids are all included, but in various states they may also require other controlled drugs. They are recorded. Prescribers are generally required to use that prescription drug monitoring program, and pharmacists are to check it. And the whole idea there is, of course, to identify shopping, quote unquote, and reduce that as a capability. But it has some other great benefits too. Pharmacists tell us, for example, that they some errors that way, and so it's great to see that these programs are widely used now. So we are going to go to the questions now. And again, to submit a question on your computer, please enter your question under the tab marked Questions. Simply type your message in the box and hit Send. If you're logged in using the mobile app, you can ask your question by clicking on the question mark located at the top of your screen. And again, when possible, please direct your question to the appropriate speaker. And also, I mentioned earlier, you can get a copy of the speaker presentations. You can access that under the handout tab on the GoToWebinar portal. So there were some slides there I know you're going to want to take advantage of, so please feel free to do that. Okay, time
Mike?
for the question. Yes.
Before we go to the questions, I wanted to point out something on slide 44. 44, I'm sorry, slide 44, where I actually wrote caution with opioid use and non-cancer pain. Oh, no, that's not the one. I actually put on the fentanyl patches that they should be used in opioid-naive patients, and it should be opioid-tolerant patients. Sorry about that. Slide 44, patch recommended only in opioid-naive patients, should be tolerant patients. So I really apologize for that. We'll get that fixed before we put the handouts out there. Thank you, Mike.
Yeah, I think would have recognized that as a mistake, but that is a problem, and not a mistake necessarily. It's really something that's intended sometimes, and as you know, we've had deaths. You know, it's been prescribed, for example, by dentists. You know, for young kids in our area, we had a death not too far from our office, and you see that once in a while, and I think it's more a lack of knowledge about the drug. We also see it used for acute pain rather than chronic pain. We see it used, you know, without any realization that it takes some for, and I obviously go on and on with that. But at any rate, let me get to some questions. And you know, some of these, oh boy, they're tough. They are tough. I hope you guys can. No, I'm kidding you. You'll probably be able to get to most of these. Let's see. Someone asked, is there a universal reporting system for adverse drug events? Sure. MedWatch, FDA MedWatch, or ISMP. We take the medication errors, and everything that we get goes to MedWatch. Automatically, we transfer. We have a memorandum of understanding with FDA, so that information reaches FDA. And so if you wanted to report a medication error, we'd rather you send that to us, and we'll pass it on to FDA at any rate, and you can be identified if you so choose. So we do have that system. Our cumulative metrics available. The MedWatch data is publicly available. It's on a quarterly basis. And as a matter of fact, this week, and we've been doing this for a long time, we publish what is called the Quarter Watch, where we look at the data from FDA's MedWatch program, and we identify interesting topics for discussion in our newsletter. In this week's issue of our newsletter, we're going to have something on drug withdrawal, not just opioid, but other drugs that patients suffer withdrawal syndromes from that you may not be aware of and may not necessarily be in the literature, in the package insert I'm talking about. And the handling information is not necessarily there either. So we'll be talking about data from MedWatch program that shows this is a big problem. And then we'll have some other issues as well in our next issue that also come from the MedWatch program. So, and then here's another one. This is, I'm not sure, I don't know how familiar would be with this because this is more the monitoring of patients, but the question, what is your opinion on using non-invasive minute ventilation monitoring for patients on PCA or opioid infusions? Maria, are you familiar with minute ventilation? I guess
no, I'm not. Sorry, I'm for the capnography. That's pretty much my end of it. Sorry. How about you, Matt?
That's what. No. But there is some literature apparently that you know, compares the two and does show some favorability with the minute ventilation. So you can find that pretty easily in a literature search. Here's another one. And maybe, Matt, I'm not sure if you'll remember this either, but this is for you. It says in 2015, CMS proposed a quality measure for monitoring of opioids. And I guess they used NQF for that. So you may have been involved. And any indication that CMS will actually come out with this proposal again for it to be considered? The person that's asking this question is not apparently has not seen anything on that. Do you know of anything on that, Matt?
Yeah, no, Mike, I'm not familiar with that at this point either.
Okay, I understand. Let's see. Are organizations limiting the number of days a prescription can be written for opioids? For example, and I'm talking hospitals, at discharge, you know, like a 5-day supply or a 7-day supply maximum. at discharge. Maria, or
I believe a lot of our practitioners are doing that now, just giving a smaller number of supplies and then evaluating the patient after that based on a follow-up. I think that's where we got into a lot of trouble, where you go to the dentist, you get 30 Percocet and you use 2, and the stuff remains on your shelf. So by limiting that supply, there'll be a lot less needed for diversion. And I think often giving the patients a titration plan, if they've been on opioids for a period of time when they're in the hospital, would be a good way to go, instead of just discharging them on the dose that they were on and continuing with that. That can create some iatrogenic problems.
Yeah, thank you for that. Actually, not to pick on dentists, I really don't mean to do that, but it just reminded me that I had some conversations with dentists at a committee meeting, and it was noted that a lot of times they will prescribe opioids like Vicodin, or whatever, and they will give a full week's supply, and many of the patients will just use a few of these and then never use the rest of the supply, and it has to be returned, or for these programs, or they get rid of it otherwise. But there's always that danger that when it's sitting around, obviously in a medicine cabinet, there's other people in the house that could use it, or even the patient later on, and who knows what might happen in that situation. Obviously, most times nothing, but it is a potentially dangerous situation. So I think many of the prescribers out there are learning to really decrease the number of tablets for acute pain when it's prescribed, and if necessary, new prescription. I do think one of the pains that has come from addressing the opioid issues, and this is quite a few years old now, is some of the burden that it's put on patients that they can't easily access the prescription. It can't, in many states, it can't be sent electronically. Sometimes sick patients, pain, that are by themselves, literally have to go to the physician office to pick up the paper prescription, and then that to the pharmacy to get filled, and that's burdensome, I think, for the patient. I wish there was a way around that. Let's see what else. Is the Joint Commission working with FDA on a Dear Doctor letter to prescribers for better opioid prescribing behaviors and explanations to patients the correct use of opioids? And I'm not familiar with that. I do know that our new FDA commissioner, Dr. Scott Gottlieb, has made the opioid crisis a top priority to address. And I know that I think it was just yesterday or the day before I identified in the media that he was pushing for the idea of educating all prescribers on opioid prescribing, and even making that education, possibly making that education mandatory. So it is a big item. I think pharmacists need that education as well. They need to know how to identify prescribing problems. And so far I haven't seen that include pharmacists. And that's also, by the way, with using benzodiazepines at the same time. A lot of times that gets missed, and that is another issue. So anyway, I don't know if Joint Commission is working on it. Maria, you mentioned the new guidelines from the Joint Commission, so that was good to see. I don't know if they're working directly with FDA. Next question. How have you dealt with physicians or facilities that use long-acting opioids for acute pain in opioid-naive patients? Kind of related to the fentanyl patch issue that I mentioned, but they're talking more likely OxyContin, for example, where they prescribe that for acute pain. And that might be done by the orthopods, might be done by other services post-op. Maria, any comments on that?
So I think you have to, that's another place where you're going to individualize your therapy. Low-dose oxycodone is only 4 Percocet a day, if you think about it. It's 10 milligrams Q12. And if you're going to anticipate that the pain is going to be there for a very long period of time, it may be something that you can do, put them on long-acting and then titrate off. It's easier to titrate your patients down on long-acting versus short-acting. But if you know that pain is going to get better, it's probably inappropriate to do. And if you know that that pain only has a short time frame, is probably inappropriate to do. But there can be situations where it can be used very well.
Okay, thank you for that. And I'm sorry to give you a workout, but I see a couple here that are directed at you, and I see one for Matt. Let me do the one for Matt here. At times we have range orders for hydromorphone 1 to 2 milligram. We're debating whether it is better to allow the nurse to administer a 1 milligram dose from a 1 milligram syringe and a 2 milligram dose from a 2 milligram per milliliter syringe. However, because these are not the same concentration, it requires a barcode scanning override. Is it best practice to accept a barcode scan of 1 milligram per mil concentration or 2 milligram and a 2 milligram per mil concentration for these orders? Or is it best practice to not scan and have the nurse override the barcode scanning requirements? I would appreciate your perspective. Matt, any comment on that? I'm thinking, boy, a high alert drug on hydromorphone, you'd want to preserve the barcode scan, but I don't know what you're thinking.
Yeah. Well, Mike, I want to take a side step here. I'm concerned hearing that an range order for 1 and 2 milligrams of Dilaudid or hydromorphone. I mean, we already, you and I learned years ago that was the old starting doses in the old package labeling for hydromorphone years ago that we got changed down to 0.2 to 1 milligrams. So first off, I'm questioning why there's a 1 and 2 milligram order unless it's for a chronic pain or, pretty opioid tolerant patient. So that's the first thing I think we have to address is evaluating that dose. Now, that being said, I'm with you 100%. I mean, you got to use the barcoding system the best that you can, Mike, right? And I agree. The alternative should not be have not used it and document it manually. So I would hope to get it as close to specific dose as possible. And that being said, they make 0.5 milligram per ml, 1 milligram per ml hydromorphone and Dilaudid out there to try to get as close to a patient-specific dose as you can. Anything else, Mike, to add to that?
Yeah. Thank you. Maria, back to you.
Yeah.
Has there been a correlation shown between the decrease in availability of psychological services and an increase in opioid addiction? Do you know that?
I would say that many of the patients, most of the either chemical copers or addicts, have psychological comorbidities. If you have good coping skills, oftentimes you can tolerate more pain than if you don't. If you don't cope with that pain, if you become very fearful of that pain, if you have anxiety and depression, that may, your nerve endings may talk to those pain nerve endings in your brain and develop anxiety and depression, that can actually sensitize your pain system. So there is a correlation. I wish we had a pain psychologist here, a pain psychiatrist. I feel that every institution should have one, or there should be some available in the community, because that's where we really, in the chronic non-cancer pain, where we have to work. That's why we see meditation working for patients, because when you use meditation for pain, you accept the pain and you learn how to accept the pain. And once you do that, your pain often will decrease. Does that answer the question?
For me, it does. I hope it does
Okay.
for the question. Here's another one. I guess either one of you could do this, but what do you do for a trauma patient who has a history of substance abuse that has been on high-dose opioids while in the hospital, and other services want the patient discharged, but the patient may still be on a high-dose oral opioid despite using multimodal therapy? Pain management or addiction medicine referrals may not be an option on discharge. A little complex, that question there.
That is a tough one.
Yeah.
So, something that, is we're using more and more often for patients that have sensitized pain is ketamine. So that's not necessarily always well accepted in the institution, but I have seen dramatic changes on someone with sensitized pain that you may be able to use ketamine. If you get them to a pain expert, they possibly can get down to use buprenorphine or methadone. Some people, when they convert people to buprenorphine, what they'll do is stop all opioids until the patient starts to have mild withdrawal, and that's when they'll start the buprenorphine. So that can be another option if you have someone that will be prescribing that for your patients.
Okay, thank you for that, Maria. Let's see. Oh, there's a question here about, was that a typo with the fentanyl patch? And
yes, that was a typo with the fentanyl patch. Sorry about that, guys. Have to make one mistake presentation.
You explained that already, so I won't go over that again. Let's see what else. Boy, we have a lot of questions here. Thank you for a wonderful presentation. What are your thoughts on peripheral nerve blocks being used in place of opioids post-op? Any experience with that?
We use them in our ortho patients, so we have great success with peripheral nerve blocks. By using that as part of the multimodal plan, we're able to usually get patients on oral therapy by the next day and, mobilizing around a lot easier because they are on oral therapy. So you just have to watch that the leg isn't still numb when you're starting to mobilize because you don't want the patient to fall.
Very good. Maria, I guess, do you use capnography there at your hospital?
No, we do not. I'm sorry. We're looking at it and determining in the PACU. We're developing new PACU guidelines. Like I said, for a while, they were just assessing pain and not sedation, so we're moving towards doing both of them, especially in the recovery room, and looking at those high-risk patients who may, assess out for sleep apnea, have undiagnosed sleep apnea. Our anesthesiologist will do stop-bang, which is an assessment for sleep apnea. And so that would be a good time if you can't get capnography for everyone, if you can at least assess for the potential for respiratory depression and use them on those patients. So hopefully that will be in place soon.
Okay, thank you. Oh, somebody did comment on, they're saying, my comment before that all states have the prescription drug monitoring programs. They're saying Missouri still has no prescription drug monitoring program. I said all because I saw a lot of discussion about Missouri specifically, and I thought they had finally agreed to do that. I obviously must be wrong if this person is right, so I apologize for that. But at least 49 states, and I guess territories probably have it as well, have these prescription drug monitoring programs. We have so many questions. I'm never going to get to the end, but or to all of them, and our time is pretty much up. We just have a couple more minutes. So I'm going to go to the end of the pile of questions here. And does either one of you have any experience with using on-cue during surgery and post-op for surgical procedures for pain management when the patient goes home with it? On-cue, that's the Celastic pump that you fill out. It's a balloon pump.
Now. We used to use that here, but it got very expensive, so we just went to the peripheral nerve blocks. So that was, it had worked before, but it was very costly to use them.
Okay, thank you. Let's see. I had one here from Matt. Oh, sorry about that. Nurses complain about using Dilaudid because it requires a waist with almost every administration. I think they mean the hydromorphone, no matter what brand it is. Dilaudid is a specific brand now, so we should recognize that. But at any rate, it says 0.2, 0.4, 0.6, 0.8 are more equivalent to common doses of oxycodone and morphine. I'm not getting this, so I don't know if you
so what they're saying, Mike, is like because syringes are 0.5, we have a hydromorphone dose, a standard of 0.4 of hydromorphone is pretty much equivalent to a Percocet. So when you have a syringe of 0.5 and you're always giving 0.4, a nurse always has to waste. So I think there's, that's a lot of nursing time, and I was just asked to run it by my committee if we could switch the hydromorphone initial dose to 0.5 because that's how they're available in the syringes.
Okay. Thank you very much, Maria. I do want to comment on one other. We didn't get to it, but we ran into this situation. We did a survey a while back. It actually involved the Carpujects, but it doesn't matter what the prefilled syringe is. The idea of diluting the contents, that seems to be pretty common where nurses do this, and it's unnecessary, at least according to the labeling. It doesn't say to dilute it. They do it for various reasons. We've had that in our newsletter. There's a risk that goes along with that, and for example, sometimes we've seen prefilled saline syringes used as the source for the volume, and they'll squirt the drug into the prefilled saline syringe, which is now, of course, labeled prefilled saline syringe. And not relabeled, and then it's set down on a counter and someone else puts saline, and they use that as a flush. So it's things like that, not relabeling them, that are very risky. We understand why it's done. It does help to provide a slower injection, et cetera, but really it needs to be thought out. And when we did our IV push guidelines, we did not give a lot of support to diluting it down. I am so sorry. We have probably at least as many questions as we were able to get to already. I want to thank our speakers again, and maybe even give them a little bit of a job, because we can get at least some of these questions perhaps on our website. Maybe we'll get together on that and make that available. But Matt and Maria, thank you very much for a terrific job. And Fresenius Kabi, thank you very much for allowing this to happen. We had almost 1,000 people online, which is tremendous. And that means a lot of learning from a lot of people. And that's just the telephones. It may have been, 20 people in the room. So that's fantastic. So let me take the opportunity again to thank the speakers, and a big thank you to all the listeners, too, for participating in today's webinar. And that now concludes our webinar. Please enjoy the rest of your day. Thank you.
Yay. Yay. Yep, it's over.
It was 650 something last I saw. They're dropping out now, obviously.
Oh, yeah. Well, she'll know how many we had.
Yeah,
right?
yeah. I said I looked on it when we were done.
No, that's the max.
That's the max.
It's going down. You can see people
it was about
hanging up the phone.
650.
That's enough.
Yeah.